Hello, I'm Dr. William Tremaine. I'm a gastroenterologist in the Division of Gastroenterology at Mayo Clinic in Rochester. And I'd like to review with you some information about an interesting and somewhat provocative study that will be published in one of the premier GI journals, Gastroenterology. That is a journal that has a high impact factor and that attracts very high quality publications. This publication is a review article, and it was from authors at Mount Sinai Hospital in New York City and from authors in Edinburgh, Scotland, and one author from Belgium. And they looked at patients who were on therapy with immune modulators. That's drugs like azathioprine, mercaptopurine, and methotrexate, and also patients who may have also been on anti-TNF drugs like infliximab or adalimumab or certolizumab, and patients who were on dual therapy with an immune modulator and an anti-TNF therapy. And they looked at what happens if you stop one or both of those drugs. And this was a retrospective study, so they looked at already published articles. They looked at over 6,000 articles, and then they winnowed that list down to those articles that looked high quality, and they got down to 69 articles, and only 7 of those 69 were actually randomized controlled trials. That's the gold standard article. That is articles that have some patients take a placebo and some take the real drug. The others were open label or retrospective studies. And they looked at both Crohn's disease and ulcerative colitis patients, and they were interested in what happens if patients stop one or other of those drugs. Now that's of great interest to patients because many patients who get on these drugs have concerns about potential adverse effects from the drugs themselves. The drugs can increase the risk of infection and the risk of lymphoma. So at some point, and particularly in a patient who's doing very, very well with their IBD, they question, do I really need to stay on one or both of these drugs? Is the risk of the drug worse than the risk of the disease? So you could look at the results from this study in a couple of ways. The conclusion was that for both ulcerative colitis and Crohn's disease, that the risk of stopping one or both therapies, the risk at 1 year was about 50% of patients will have relapse, so half will have relapsed. Well, you could also look at half will not have relapsed. And then what about at 5 years? About 70 to 75% will have relapsed at 5 years, and by 10 years up to nearly 90% of patients will relapse. So you could say, well, the odds are not good, but are there subgroups? What can we understand which groups of patients won't relapse and that we don't have to continue the medications? So they looked at those factors, and there are some themes. Now you can imagine this was a heterogeneous group of studies. They all weren't done the same way, so it was hard to bring any absolute conclusions from these studies. But some generalizations do exist, and that is the longer a patient had been in remission, the more likely they were to do well with stopping therapy. Now remission wasn't just feeling good, it was also that laboratory studies were normal and that the x-rays or colonoscopy exams were also normal. So a patient who's been in remission, say for 4 years or longer, had a pretty good chance of staying in remission when they stopped the immune modulator and or the biologic therapy. Likewise, we can now measure those blood levels of those drugs in patients, and the patients who had very low levels of the drugs in their bodies, that is, so low that they were doing well in spite of therapy, despite the therapy, well, those patients could do very well with stopping therapy as well. Also, it looked like older patients, that is, patients age 65 or older, were likely to do well with stopping therapy. Now, you could argue that if they've gone to age 65, they've had disease for many, many years, then they may have already proved that they don't need surgery, that their disease isn't severe enough, although that's not always the case. But the other thing about older individuals is the immune system becomes less active with aging anyway. So older patients are more likely to get shingles, so they need a shingles vaccine after age 60. So in older patients, with a less immune response, there may be less of a need for immune suppressive therapy. So patients with long-standing quiescent disease, older individuals, and those patients with lower blood levels of the drugs may do very, very well with stopping therapy. So doctors may be able to pick subgroups of patients who we can say, well, you're doing so well, we don't have to keep you on this therapy. So I think if we look at the cup as half full and as half empty, this article is very exciting in terms of giving doctors direction for future treatment.